Relatively important. It'll touch on multiple points that you guys have heard throughout the day regarding the need for planning for these surgeries and why the planning is important. Here are my disclosures on all four kind of categories. So I think at this point we were all relatively aware that spine deformity, right, causes disability. We've gone through that ad nauseum, and then we can correct it to improve alignment as well as improve quality of life. But the problem, though, or some of the challenges then, is what alignment do I really need? I don't think it was really dialed down what alignment would be ideal for a patient, but then also how do I correct it? Manish has gone through how to perform an osteotomy and when to, maybe worth diving a little deeper in terms of, in my thinking, when I decide to perform an osteotomy, especially 3-column osteotomy, what the UIV and LIV should be, and maybe some potential pitfalls. And so if you look at what the ideal alignment is, I think, from the sagittal plane, spinal pelvic, so Frank Schwab put this out on retrospective analysis, usually SVA, less than 50, lordosis gap, less than 10, roughly. You guys are all familiar with this. And then a tilt less than 20. And then we in the ISSG look at this again, and we use an ODI of 40 as a cutoff, and we actually roughly got to these same values, right? Tilt greater than 22, SVA greater than 46, and lordosis gap greater than 10. Those patients had an ODI greater than or equal to 40. You guys are all familiar how the ODI runs, right? So 40 is a cutoff for severe disability. It's actually the only HRQOL that's actually authorized to actually use the term disability with it. SRS 22, SF 36, those kind of things don't correlate with, quote, disability, but this is actually measured for disability. So ODI cutoff of 40 gave us those relative values, but then those alignment goals were then subsequently integrated into the SRS Schwab classification. But I think that what you have to remember is that these are going to provide a relative ballpark for us. And so what's evolving really are these patient-specific parameters. And I think that we go in the lab and we learn different techniques of how to do surgery and how to employ different types of osteotomies and how to slap in screws. But I think in the end, we need to think, well, why are we really doing this, and what should we be aiming for? And so I think that while the SRS scheme and these alignment parameters initially give us something to look at, and that's the beauty of it. It says, well, you need to actually put your brain to this and get some of this on a piece of paper where a patient is and maybe where the patient should be. But now what's evolving now, I think, are patient-specific parameters, initially from an age standpoint, but also then from a physiological standpoint. So then as we've seen, right, undercorrection or too little surgery is probably going to result in maybe a safe surgery, but residual disability, so they still go through some risk with not a lot of benefit. But then overcorrection, too much surgery, is going to be a patient, either a surgery they can't tolerate or an alignment they can't tolerate and are likely at risk for failure in that setting. And so what's evolved in this, and it's probably worth either handing this slide out to you guys or looking up this reference, Renaud Lafage, and we did this with the ISSG in 2016, is we correlated generational specific HRQOLs, health-related quality of life metrics, using SF36. And then we found those patients that were within generational norm, right, and what those sagittal parameters then looked like. And so obviously then what happens, as we all know, with increasing age, you get increasing sagittal malalignment. And if you normalize that to generational quality of life, then what we're seeing is that the 35-year-old and the 75-year-old don't need the same SVA. They don't need that same reduction in lordosis gap. When I say lordosis gap, I mean PI minus LL, right? And so you need to relatively temporize what you're doing for each patient specifically, right? And so if we're going to tackle these surgeries, I think we need to start using the brain where we say, okay, we're going to measure, and what is my patient's problem, and what are the identifying outlying aspects of their alignment, and then how can I correct that to tailor it then to what their needs might be. And then we also then looked further, and we saw that if you went beyond the correction, right? If you exceeded those age generational alignment parameters, they're at enormous risk for junctional kyphosis, namely overcorrection, lordosis gap, as well as overcorrection of SVA. Put them all at PJK risk, and it was actually relatively linear relationship between the amount of overcorrection correlating with greater junctional kyphosis angle, right? Because PJK is obviously a spectrum then of a phenomenon that can range from benign kyphosis all the way to catastrophic failure. So if you continue to overshoot those parameters, right, and do massive and bigger surgery because you haven't planned it out, you really put your patient at quite a bit of risk for overcorrection and junctional failure. So then if we then look then at junctional failure, I think this explains what's happening with these patients. If I extrapolate with these two cases of PJK or PJF, where the head would be if I take what these forces look like, maybe this would be a sustainable SVA, but there's no way that patient is going to maintain that SVA. So of course they're going to pull over. And so these examples then in correlation then with age-specific parameters and measures really explains why these patients are failing, right? And these become really big problems to deal with because now you need a second surgery to revise that. And then what happens, unfortunately, is that you kind of keep adding on to that and they keep failing over. The other piece also, why this makes sense is from a physiology standpoint, the older patient is not going to be able to tolerate this massive correction. They don't have the physiology to sustain their new alignment. And so I think that if you look at the problems that go with junctional failure, it's an alignment problem, but it's also a physiology problem as well as a fixation rigidity problem. So then our solutions for this that pertains again to planning, it's going to be alignment thresholds, accurate rod contouring, and then having prediction models for failure that Kevin spoke to that we're working on currently. So then if you look at what my decision making is, then in my mind, the deformity drives my correction, namely what I'm going to do, right? The magnitude and the flexibility of the deformity. But then the patient's age and physiology is going to temporize what I do. Again, they have to be able to maintain and tolerate the surgery. So then I think that we have to kind of integrate then what the recommended correction is, what the achievable correction is based upon our studies, and then what's going to be tolerable. And clearly, one size is not going to fit all. So if you're a hammer and every patient looks like a nail, again, we're going to get our butt burned several times. So we need to, again, start thinking through this process. I'm a little frozen here. Can you advance that for me? Hello? Will that advance? It's going to crash. There it goes. I think the computer's saying Saturday afternoon also. All right. So why don't we go across the room now? Who here is routinely, if you're doing a large realignment surgery, who here would routinely measure sagittal and coronal parameters on a regular basis? Who measures that? No. Some yes and some no. And who here is going to routinely then plan out the surgery? Say, well, based upon those parameters, I'm comparing them to what I think they should be. Are you comparing those parameters to anything? Yeah, some are. And then who here now is actually then planning out the surgery to weighing the pros and cons of doing an osteotomy at one level versus another to try to reach identifiable parameters where you want to reach. Yeah, so probably worth doing that. I'm not going to make a plug for one program or another, but I think the beauty of the programs that exist right now don't lie in so much in the accuracy of what you'll actually get, but what it does lie in is taking you through the academic steps of actually consciously mapping this out. It's a good exercise to do. It's a good exercise for you. I think it's a good exercise for your patients, and it's going to make you a little more conscientious in your surgery. You don't feel like you're winging it quite so much. And I hope, again, as we do these labs, that you get techniques, but the real thrust of this goes into taking the time to plan these things out. Where do we stand on the... Oh, we're going to reboot the computer. All right. You guys want to get some more cake? Right. And as you go through, I think as you go through and plan on a regular basis, you're going to find that you're going to be much more able to refine your techniques and improve upon what you can do, what's going to be achievable, and where your complications and your errors are going to lie. So, where do we stand on the computer now? What do you guys in the audience then use for any planning? Those are Kush. What are you planning with?
I measure all the parameters.
With what? Do you measure on packs or you measure on? You measure by hand, so you don't use an electronic program?
To get everything, I do a surgery with another surgeon.
Uh-huh.
He'll sometimes put it into surgery now.
Uh-huh.
Usually all the decision making is made at the conference. And measure all the parameters by hand. Usually some discrepancy.
Mm-hmm. Mm-hmm.
Try to decide.
Mm-hmm.
It's at least 30 or 40 degrees.
Yep.
It's more likely than osteotomy.
Right. Well, here we go. What do you do, Serena? On the pack system. Yeah. Okay. Packs. Yeah.
I find the packs really cumbersome because you know how you draw the circles and you have to like make the right angles and measure, or is it automatic?
You can take screenshots of it, though. Interesting. So it's interesting. So we did the study back in 2012. I think one of the first things we wanted to look at is, okay, you got to be honest in terms of how much correction you really think you're going to get with the 3-column osteotomy, right? And what we found is that you can get about 28 degrees of lumbar lordosis, plus minus. This is probably some of the best folks. This is Manisha's cases. This is Wachi's cases. This is Larry's cases. This is Bob's cases. And you're going to get about 90 millimeters of SVA correction. But then what we did is we broke down PSO successes and failures. And we used a cutoff of SVA just roughly of 50 as a success, and then over 100 as a failure. And what we found in this cohort of people who I think are relatively thoughtful surgeons, it's interesting that because the level of the PSO, the distribution was the same, the resection angle of the PSO was the same between the groups, successes and failures. The change in SVA, lordosis gap, and tilt was the same. So what we're saying is, what happened for the successes and failures, they all received the exact same surgery, but the difference was, is the successes or the failures had larger deformities. Really simple stuff. But what this is saying is, if you go in and you say, I do an L3 PSO and I go from T4 to the pelvis. If you do that every single patient and you don't plan, you are rolling the dice for a success and a failure. And I would hope that this paper, which I thought was an important paper for us, is that if you don't plan these out ahead of time, as clearly the surgeons weren't planning, this is our group, which was very humbling to see this data, is that probably several weren't planning these surgeries out and they were just cookie cuttering our approach. And so what we found is relatively risk factors. One, as your SVA is greater than 200, if your tilt's greater than 40, or your lordosis gap is greater than 45, if you just do a PSO And if you just go T4 to the pelvis, they're going to be undercorrected. And they're going to come back and they're like, I'm still forward and I'm really unhappy. So again, this drives home not so much technique, right? But you got to plan these out because you're going to get your butt burned if you don't. So what do? I think that you guys have gone through this ad nauseum today, right? I get standing AP and lateral films, and I, again, measure the parameters. There's no need to go through that. But then I get flexibility imaging in all my patients. You can see this 7-year-old. Here are my age-specific goals: lordosis gap of 10, SVA of 54. As she is here, her SVA is 150. Her lordosis gap is, what is that, about 30, right? But you can see when I get a supine lateral, she corrects really nicely, right? And so in my mind, the deformity and the flexibility of the deformity is very integral in terms of what I'm going to do. So I'll get a standing AP and lateral and then a supine AP and lateral on every single reconstructed patient that I'm going to do. And you know, I think you can use as a surrogate the MRI scan, CT scan lateral, right, or sagittal views as a measure of flexibility. But when they're in the CT scanner or the MRI scanner, they've got their knees bent, they're drinking a Coke, they're super comfortable. Whereas if you put them lateral on the table and you try to flatten them out, that's really how they're going to be when they're on the table. And it really gives you, I think, more accurate measure than of what the flexibility is. And I think in this relatively flexible deformity, there's a relatively large deformity, but it corrected very passively and nicely. So I was able to correct that with really simple little type 2 osteotomies about the back, as well as using the implants. But problem, though, is what I did not do in this case is I didn't measure the age-specific parameters, partly because I didn't have them at that time. And you can see that I've overcorrected this patient, and she didn't catastrophically kyphose, but you can see she for sure has PJK, and my little dinky hooks at the very top just aren't cutting it here, right? And so my age goals would have been a lordosis gap of 10, but I've got below 6, so I overshot it. My SVA should have been 54, and I got it for 10, so overshot it on that patient as well. So I think it's worth measuring, one, the flexibility of the deformity, but then also integrating these concepts to it. And then I'm going to speak to what Manish was saying as well. I think people, to some degree, are moving away again now from 3-column osteotomies posteriorly because of the number of complications. I do a fair amount of anterior surgery for that very reason. Right, and so this is a 62-year-old female, had 10 prior surgeries. I did this about 2 months ago. And you can see that she's fused, what is that, from roughly 3 down to S1. And she's got a number of problems here. She's got PJK at the top here. She's sagittally malaligned. Her SVA is 119. Her lordosis gap is 50. So fairly decent deformity. She's obese. Has multi-level non-unions. You can see very wide laminectomies, but not a whole bunch of interbody support. They just kind of threw some plastic in here. It didn't really work. And so what are her problems, right? She's got a non-union, and she's got sagittal malalignment. But what happens is when I put her flat on the table, you can see her coronal malalignment. She flattens out really nicely. And her sagittal alignment, I had to heighten this right here, she comes across very nicely as well, right? And so then there are the wide laminectomies here, here, and here. And here are the vacuum disc signs across all these areas that are non-union. So I can use these non-unions then to my advantage to restore a sagittal alignment, but also then use that same problem that she has to attain a solid fusion. And so again, I need to restore alignment, need to get a solid orthodesis, but it's a flexible deformity moving through these non-unions. So I did a 2-stage, right? I did a 2-to-1 anterior, and you can see she came back to roughly where we thought she was going to be. And I don't think I need to do this back, front, back, because she moves to those non-unions, right? The pedicle screws are already haloed, so she's going to pull back. And then once I bring her back, and I get those implants out, I'll be able to jack her up a little bit more, and I just use these temporary, these fixation screws just so that the cages don't pop out. And so then we pulled her back relatively nicely by then going from T3 to the pelvis. Actually, I stopped at 5, and then this is off-label device, but I used a tether at the top to try to prevent proximal junctional failure. Because again, these patients, if you don't do something at the top, they're going to get failure. So here she is, relatively recently out, but brought back fairly well. Again, using those non-unions to our advantage, and then obtaining anterior column support for the patient. In my mind, choosing between the UIV, upper thoracic versus lower thoracic, is sometimes obvious, sometimes problematic. Again, in this patient, right, large deformity, you're going to go to the upper thoracic spine. You know that. So on this patient, we went up to the upper thoracic spine, did multi-level osteotomies, and got a fairly nice correction and anchored down to the pelvis on her. But I think in some of these patients, it's not really obvious, right? This is a 74-year-old female, right? Her malalignment is worse in the sagittal plane than it is in the coronal plane. Actually is solid down through here. Thought as well, if I go to the thoracolumbar junction, is she going to do this? And I'm going to have to do that. Or if I go to the upper thoracic spine, is it too much surgery, or is she just going to topple over the top and then do that? So we have some data on that, again, through the ISSG, through 2 studies, one that Chris Ames did and one that Hanjo Kim did, and really found that maybe a little bit more blood loss and maybe a little more, though, maintenance correction if you go to the upper thoracic spine. And I think if you have a large sagittal deformity, if I look at this patient here, right, I'm just not going to have enough lever arm to be able to maintain the sagittal alignment that I dial in. And it's same for this patient here. I'm just not going to be able to, in my mind, pull her back and maintain that correction. And lo and behold, that's what Hanjo and Chris showed, is that, again, over time, you're going to have a probably greater loss of correction stopping, especially for large deformities at the thoracolumbar junction. So to wrap this up in terms of decision making, I think that, again, if I could drive home one piece from this course is please measure alignment and please plan it out. It's not hard. And just think a little bit for these surgeries for your patient, right? And so that will then integrate how you then use different techniques to then achieve and then also maintain the correction. We know that undercorrection is going to give residual deformity. Overcorrection, though, is going to be intolerable. And that's why we need to thoughtfully think through these pieces. I think the next steps, though, really are patient-specific thresholds beyond age and differentiate between the patient who's 50 going on 80 versus that patient that's 80 going on 50. And I think we all have patients like that in our practice. And you have some kind of gestalt of, well, this patient's just not going to tolerate it, or this patient probably will tolerate it. And that's going to probably temporize or drive our correction maneuvers, and then also help us plan and accurately perform surgery. Thank you.